what biomarkers are out there? Do we use anything as standard of care to guide treatment, and just kind of the current clinical picture of biomarkers?
Yeah, absolutely. This has been something that's been elusive for some time in kidney cancer, but also, one might argue up until a number of years ago, they might not have been as useful because biomarkers, I think, are most helpful when you have effective therapies, and particularly when you have multiple potential effective therapies, and it really might help you to choose between them. And so in our cases, we might care about biomarkers because it might help to prognosticate how well a patient might do overall. It might help us to choose between different types of therapy. And for kidney cancer specifically, and frontline therapy, thinking about a pure immunotherapy strategy versus an immunotherapy combined with an anti-angiogenic. It might help us understand things like toxicity. We don't, I classically don't think of biomarkers in that vein as much, but that's certainly an important sort of emerging field. And then in what's a relatively recent development in kidney cancer with potentially effective adjuvant therapy with pembrolizumab, really trying to think about who's going to benefit, who's more likely to benefit from adjuvant pembrolizumab versus not. And so lots of sort of reasons to have good biomarkers, but it's been a tough road. And so in kidney cancer particularly, there's been a lot of exploration of things that have been looked at in other tumor types, classic things like what is the PD-L1 expression by immunohistochemistry in the tumor, what's the total mutation burden within a tumor, all of those things which seem to have a predictive value in other tumor types for PD-1 axis blockade just hasn't consistently panned out within kidney cancer. And so could talk for a long time about biomarkers in kidney cancers and successes and failures and what's sort of coming. But I think really the one in my mind that is clinically actionable today, and I hope again it's different tomorrow and a year from now, but the one that's clinically actionable today is potentially one of the oldest things, which is looking under the microscope and seeing sarcomatoid differentiation and maybe to a certain extent rhabdoid differentiation as well. These dedifferentiation states, which can occur in clear cell, but other RCC histologies as well. Those are historically associated, as we know, with really aggressive disease biology and really often, unfortunately, not great responses to tyrosine kinase inhibitors. And it really seems to turn around largely in the setting of immune checkpoint inhibitors. And probably the most robust data is from a post hoc analysis from the CheckMate 214 trial of ipilimumab plus nivolumab, where those patients with sarcomatoid differentiation who received pure immune therapy, nivo plus ipi, really had tremendous responses. You look at nearly 20% complete response rate, probably around a 60% objective response rate, the really flattening out of that progression-free survival curve. And so out of all of the technologies we have and things that I've explored, I think right now the main clinically actionable thing would still be the presence of sarcomatoid histology, really pushing you towards certainly using immune therapy, and in my mind, a good amount of evidence for dual immune therapy with nivolumab plus ipilimumab.
That's great, and I think that's a wonderful point to highlight. Really enriching for response with that really aggressive feature on pathology. And maybe one other thing, just to kind of before we get to the paper, to ask about in your practice and where you see it being used now and maybe going forward in the future. I know there's a lot of discussion out there about IMDC criteria. We've used it for a long time, developed during the era of sunitinib, TKI therapy. But ultimately, it was used really to design some of the primary endpoints, not primary endpoints, but rather, I should say, the kind of stratification and how we were looking at the overall groups in, for example, CheckMate 214 and all these IO-TKIs. So how do you think about the IMDC criteria, and do you let that be a decision maker when you're thinking about frontline therapy?
It's a great question. And I think it's something that's truthfully evolved over time as we've seen some longer term follow-up from these IO-based frontline trials. And so I think overall, the IMDC has been a really wonderful contribution to how we think about kidney cancer, certainly to prognostication. And even though it was created in the TKI era, we still see these associations in the immune therapy era, which is wonderful. And I think from a practical standpoint, it's very usable, right? It's clinical factors, it's laboratory values, and so it's really easy to implement in a wide range of clinical settings. I think ultimately what the field is likely to move to is a much more biological understanding, and I think we're starting to get there. In what was really tremendous work, transcriptomic analysis of a large phase 3 clinical trial, Emotion 151, and I know subsequent work in a clinical trial that you've been involved with. The idea that there's really distinct molecular subtypes of clear cell kidney cancer, and that if you look across IMDC risk categories, that in actuality, the ones that are favorable risk are really enriched for angiogenic biologies, these angiogenic subtypes. And those are really decreased as you move to intermediate, and certainly decreased as you move to poor risk, or maybe you see more of an immune subtype kind of emerging at that point. And so I strongly suspect that what we're seeing in terms of the really sort of strong efficacy of TKI-based therapy in favorable risk might probably be really related to the fact those are enriched for angiogenic biology. And so I think right now the IMDC is what we have and has been a really valuable tool. But my hope is in the coming years, as we really are understanding the biology much better, we're going to be able to use the biology to help guide us. And I think actually the trial that you're leading together with others at Vanderbilt, the Optic RCC, which is really trying to think about different therapies for different biologies, different molecular subtypes, I think that ultimately is what the future is going to hopefully bring. Now, in terms of actually how I use it practically on a day-to-day basis, it's truthfully evolved. And so we know that nivolumab plus ipilimumab was really approved in the intermediate and poor risk groups, whereas the other IO-TKI regimens were really approved across the board, including favorable risk. And so that's something that I would say for a number of years, I really sort of took to heart, and that was my sort of standard practice, where I'd use more IO-TKIs in that favorable risk setting. I think the latest data at least calls that into question, that where, let's start off with Nivo plus Ipi. In the early days, it really seemed like sunitinib performed better than the IO therapies. I think as time has gone on, those curves have crossed. And with long-term follow-up, over many, many years later, the patients who received IO-based therapy seemed like they were living longer once you got to a certain point. So the benefit of those IO-based therapies, dual IO therapy, seems to be sort of increased. Also, as time has gone on, I think the value of IO-TKIs over TKI alone has maybe diminished. That if we look at overall survival, kind of the gold standard for any of those IO-TKI trials where it's compared to sunitinib, the hazard ratio for overall survival is really hovering around 1. And so, I think we're in a position where we don't really have an answer for that favorable risk group. I think just to throw in the mix, Mike Atkins had this really well-done study of nivolumab monotherapy, the HCRN GU16260 trial. And in that group, actually the favorable risk patients had around a 50% response rate just to Nivo monotherapy, just anti-PD-1 alone. And so I think if someone wanted to make the argument for TKI alone in that setting, someone reasonably could. Someone could probably make an argument for IO monotherapy, for dual IO, and for IO TKI. And so I think that's an area where we need better understanding of what that subtype is. I think a biological understanding and a better clinical understanding. And I think we need trials that really sort of begin to tease that out. Practically, it's a conversation with my patients, even though it's doesn't have a label for it. If patients, I think, could do well, they don't seem like the phenotype. I don't get the clinical gestalt of the phenotype of being a rapid progressor. I'll often discuss IO-based therapy, again, with that idea of durability. But it really ends up being a conversation with the patient because we don't have the strong data, I think, to point us in one direction or another.